Good afternoon, everyone. I am Dr. Vishwanath Mandel, Pediatric Orthopedic Surgeon from India. And today we are going to see common pediatric orthopedic related problems we see in our day-to-day practice. These patients may come to general practitioner, orthopedic surgeons, or pediatricians as well. So we must know the common conditions and their treatment so that we can appropriately guide and institute the treatment. So I'm practicing at my Indore at my clinic, Little Ones Pediatric Orthopedic Clinic, situated at Satyasai Square, and I am associated with Sri Aurobindo Medical College as an assistant professor in charge of pediatric orthopedic services. So to start with, how do we classify these common pediatric orthopedic conditions? So in general, just for description purpose, I have divided these conditions as what do we see, but out for observation. There are conditions where we see regularly and out for observing them without any intervention or without any treatment. Common gait abnormalities like in-toeing or out-toeing, common leg alignment issues like genu varum and valgum, and common foot postural issues like inversion, eversion of the foot and flat foot. In these conditions, we just opt for observing the condition, and they may resolve by themselves, or we may ask them to undergo some physiotherapy or some activity modification. Likewise, there are certain conditions where do we see them and seek or recommend immediate treatment. These conditions are relatively common gait patterns like antalgic gait, short limb gait, waddling gait, severe leg alignment issues like severe conditions of knee alignment issues like knock knees and bow legs, obvious leg discrepancy where we need to immediately seek treatment or advise treatment. Obvious congenital deformities like clubfoot or congenital vertical talus, which present as rocker bottom foot, hemimalias, syndactylis and polydactylis. Similarly, radial clavender, which is a gross deformity at birth itself, and we recommend treatment immediately. So there are certain conditions where we see them regularly. We know that the child has orthopedic issues and can be corrected, but we tend to opt for a supervised neglect. So the commonest among these is cerebral palsy, where the child present to us as delayed milestone development. There are certain postural issues like seizuring, abnormal gait pattern, or walking abnormalities. There are certain contractures developed already in them because of our supervised neglect. And similarly, toe walking. We tend to observe them on a regular basis, but we tend to ignore them, or we just advise them to continue some sort of a stretching or activity modification. Certainly at last, there are certain conditions where we should see them, but usually they are missed or forgotten. And among these two conditions are hip screening at birth and hip screening in cerebral palsy kids. These two conditions which we rarely diagnose on time because we tend to ignore because of our busy practice. We in a rush at odd hours of delivery, we are not observing the hip in our routine examination in OPDs. Likewise, in cerebral palsy kids, they are in general like having a supervised neglect. So we are, or maybe a lack of awareness regarding the spastic hip dislocation, which is a progressive condition. Initially, it may not be there, but later on, he may develop hip dislocation. So, and lastly, there are conditions where we know and we see, we diagnose and we treat, but should not be treated the way we treat. And among these conditions, the most important is musculoskeletal infection. Musculoskeletal infection, more specifically bone and joint infection. They should be seen, treated aggressively, and should be treated in a proper set manner of protocols, because once they are missed or once they are not treated properly, even if they they have been treated properly, they may develop complication. But if they are not treated properly, they'll develop a sequelae of infection, which will be a life-changing event for the child. Otherwise, happy childhood will become horrible for the parents as well as the child. So let us start with common gait abnormalities. The commonly seen gait abnormalities are intoing and outtoing. So intoing, can be various reasons. Showing certain examples, like in this case, if you can clearly see that child is walking with intoing, and the intoing is coming from the patella. There is a squinting of patella. There is a squinting of patella. Left side is more than the right side. You see in the second example, both the legs are going from the femur. The foot is also turned inwards. So you can see that the problem is at multiple levels: the hips, the knees, the ankle, as well as the foot. So we need to identify the cause and how to be treated accordingly. Here I'm showing you another example of intoing metatarsus adductus, which is again a congenital problem and should be treated at birth. If the child is not treated at birth, at walking age or at a later date, they may present like a fixed deformity. So similarly, there are conditions in which the foot is rotated outwards. Here are the examples. You can see bilateral outgoing gait in a child on the right side. Come back. And unilateral condition on the left side. So in the prone position, when you make the patient prone and knee bent, you can clearly see the difference in the angle of the foot. So she is having a left-sided outgoing gait, and you can clearly see that this foot angle with respect to thigh is more outwards on the left side, and that is a typical on the right side, sorry, and this is a typical outgoing gait because of the tibial external torsion. Here we can see another example of outgoing gait where the deformity is coming again from the foot as well as the ankle, and these kids usually have a planovalgus foot. So on the picture on the right side, you can see that there is a hallux valgus as well as a planovalgus, and there is a flat arch, and the child is walking with the outgoing gait on the both the side. So there are conditions where we can see both the problems together exist together. Like in this case, a case of clubfoot on the right side, and on the left side is having a planovalgus foot. You can clearly see that there is intoing on the right side and planovalgus foot on the left side. So we need to identify the cause. We need to treat them accordingly. Now, let us come to the leg alignment issues. Leg alignment issues commonly present as alignment problem at the knee. They can be genu varum or bowing of the leg, or genu valgum or knob knees. There are certain common causes. Rickets is commonest among them. Skeletal dysplasia, Blount disease, infection, post-traumatic, genu valgum or varum. Usually, genu valgum presents in late adolescent or late childhood. Commonest cause again being rickets, metabolic bone disease, skeletal dysplasia, post-traumatic or infections. Here you can see a case of genu valgum. What we see clinically in them is there is a separation which is more than normal in between the two malleoli when the child is standing straight with the knee just touching each other. So there is increased intermalleolar distance. So as a rough guide, you can observe, or you can recommend treatment based on this finding. If the intermalleolar distance is more than 6 centimeters in any child having age more than 6 years, it needs investigation and a proper treatment. It need not be observed without doing anything. Likewise, this is a 4-year-old kid and having intermalleolar distance which is quite obviously more than 6 centimeters. He needs an aggressive treatment, workup as well as treatment. Similarly, this is a case where the child has genu varum at age more than 4 years, like 5 years. And initially she was prescribed some kind of braces which actually don't work. Literature also are against recommending any kind of braces for such conditions. We have offered a growth modulation and she corrected very well within a year. So how do we decide our treatment protocol? So before deciding our treatment protocol, we should know about the normal growth and development of the knee alignment. So at birth to 16 months, all the kids are having a normal physiological bowing. This bowing tends to resolve, and by the age of 36 months, it should resolve completely. The leg should become straight. Between 3 to 4 years, the leg starts going out. The child starts developing genu valgum, and this genu valgum keeps progressing till 4 to 6 years of age, and at between 10 to 8 to 10 years of age, the normal adult alignment should be restored. So we take as an upper limit of remodeling potential as age 8. After 8, any persistence genu valgum which is more than physiological should be investigated and treated properly before the skeletal maturity arrives. So how do we treat it? Just to share about, briefly about the importance of rightly recommending the treatment in genu valgum and verum. This is one important and most powerful tool which is known as growth modulation. It involves temporary epiphysio disease and blocking the epiphysis of one side so that the opposite side epiphysis keep growing and the deformity resolves. So we put some sort of 8 plates with 2 screws across the physis, spanning the physis. It will block or it will hamper the growth on the side which where the plates are applied, and opposite side keeps growing so that the leg becomes straight over the period of time as the child grows. So it is important to know that the growth of the child is important for this technique to work. So this should be recommended at a properly timed surgery. So at least 2 years of growth should be remaining for this technique to work. How do we decide that how much growth is remaining? So commonly we use elbow X-ray where we see the olecranon apophysis. Olecranon apophysis remains like this in early childhood, maybe somewhere around less than 10 years of age. At 11, it becomes a two-partite, and we can see a clear linear line between 11 to 12. At 12, the apophysis growth grows in size. After 12 years of age, it starts fusion. Fusion starts from joint to the dorsum of the ulna, and once this is completely fused, the growth is slowing down. So if we decide about the age that it is somewhere around 11 to 12, we can institute or we can recommend growth modulation. So growth modulation works well in phase of acceleration of growth. When the growth starts decelerating, growth modulation won't work, or it won't work as per our expectation. So right patient selection should be done. So just to highlight the cause as infection, it can lead to a gross deformity which is recurring and might require multiple surgeries as well as lengthening. A similar case, post-traumatic. So now we come to the congenital foot deformities. Clubfoot being the commonest foot deformity, they can be idiopathic without any associated syndrome or without any associated deformity. There can be syndromic or secondary clubfoot where they are associated with some sort of syndrome or other structural problems or other system problems. They can be associated with neurological condition like polio, like cerebral palsy, and spinomeningomyelocele. So diagnosis is quite obvious and easy. It's obvious deformity. The foot is turned downwards and inwards. How do we treat it? Treatment is, there is a lot of confusion even in this era where a PONSETI treatment has revolutionized the treatment. Manipulation by mother is no more recommended. It is just can be recommended when the child or the conditions are not supportive to initiate plaster immediately. Surgery, again, now it's outdated. We rarely perform these big surgeries involving a lot of soft tissue releases and many wound complication and resulting in a stiff but reasonably good foot. So we don't recommend it nowadays. The main workhorse for our treatment modality for clubfoot is conservative management, which is uh, advised or discovered by PONSETI and is revolutionized and has revolutionized the treatment of clubfoot. PONSETI method involves serial casting at a weekly interval, followed by a small procedure which is done mostly under local anesthesia and involves tenotomy of the tendo-Achilles. And after that, uh, the deformity, once corrected with these two steps, the manipulation, serial casting, and tenotomy, the deformity needs to be maintained with the bracing. So we broadly divide treatment of clubfoot in two phases. One is the treatment of uh, known as intensive phase or the treatment delivered by the doctor, and second is the maintenance phase in which the parents needs to properly make the child wear these braces and do some sort of stretching and exercises so that deformity doesn't recur. So there are two stages. First stage is casting and followed by tenotomy, and second or final stage is maintenance phase where we use braces. So let me show you some example. This is a deformity child presented at an age of maybe 8 months. Deformity corrected within 2 months, and at 4 year follow-up, the child is walking so nicely. Where the foot should be corrected. You cannot appreciate this, and she is fully functional, involved in all sort of activities. So why this deformity should be treated on time? This is a classical example. A child of a sexually active age or a marriageable age, mother brought her that she is now not able to walk, and her elder sister is getting married, and we want her to get married in next few years. They bring the child in their lap, and that is how we have done a single stage correction for her deformity. One foot was corrected first. With the result, they were motivated and came for the correction of other leg also. She's working well. So this is just to highlight an example of associated condition where the wrist are flexed, hip is flexed, abducted, the foot is having bilateral clubfoot, and there can be certain other associated issues like congenital hip dislocation, congenital knee dislocation. So this is known as arthrogryposis multiplexa congenita, where more than two joints of the body are involved in contracture. Other foot deformities includes congenital vertical talus, where the talus is lying straight down the tibia, and there is a malalignment between talo-navicular joints. So ideally, this should be talus should be aligned to the navicular, and this is not aligned. After treatment, it looks like this. Then comes the toe walking. So toe walking can be pathological, like this was a case of delayed milestone with spasticity, a cerebral palsy case, and here is some idiopathic toe walking. The child puts the foot plantigate intermittently and walk on toes. And when asked to put the heel down, he is able to do so. So idiopathic toe walking, it should not be ignored. It can be associated with attention deficit disorder or autism, so should be evaluated thoroughly. Similarly, there are certain conditions which are a bit rare, but we do see them commonly, is everted foot, where the peroneal is acoustic. Now we come to another problem which is quite commonly missed, and a clinician should know how to evaluate and should diagnose it on time so that the treatment should be done properly and at right time. So this is developmental dysplasia of hip or congenital hip dislocation. 1 in 10, 1 or to 10 is the incidence per 1,000 live birth, more common in female, and usually firstborn breech delivery are high risk factors. So you can clearly see that there is a shortening of limb, there is limited abduction span. So abduction is limited on the affected side. You can clearly see that there is contracture of the adductor tendon. So on forceful adduction, the adductor tendon becomes much more apparent. How do you evaluate it clinically? You can clearly see that I put my middle finger at the greater trochanter, thumb on the medial side of the thigh, trying to push the hip in and out, trying to push the hip in and out. So you can clearly see that on pushing it down, the hip goes out and there is a visible click or clunk, and it was actually audible also. So the hip was quite unstable. You have to check the hip stability with ortholonian Barlow test up to 3 months of the age. And it should be done in each and every kid presenting to your OPD clinically, so that they can be picked up on right time, and easy treatment of poly harness can be instituted. Radiologically, we won't see much as capital femoral physis is not apparent or not ossified. So it is very tricky to observe hip dislocation on X-ray. But just to complete the presentation, you have to draw a horizontal line through the thyroid cartilage and a vertical line, which is known as Perkins line, over the edge of the acetabulum. And if you found that the inferomedial portion is lying inside the Perkins line, or lying into the inferomedial quadrant, so that's a normal thing. And if it is lying outside, either below or above the Hellringer line, it is dysplasia of the hip. So in early infancy, USG is the right way to diagnose the hip dislocation. So how do we treat it? Initially, in first 6 months, if diagnosed, we usually recommend this polycarnes. This is a very easy brace. Child is always remains playful, active, and with his activity, the hip pushes him towards the acetabulum socket and reduces and stabilizes. So that's the right treatment at right age. Between 6 months to 18 months, even arthrography and close reduction might help, but this usually should not happen if we diagnose it on time. Most of the kids, like success rate of polycarnes is almost 80 to 90%. And those who failed with polycarnes or those who presents late after 6 months has to undergo close reduction, arthrography, close reduction, and adductor tenotomy. This is how we do arthrography, close reduction, and tenotomy. You can clearly see that this capital physis, which was not visible on X-ray, is now visible by putting a dye into the joint. So that's how we check the stability. So look at this. The hip is well contained. I'm pushing it out. The hip is out. This is in. Again, the hip moves out, goes in, move out, go in. So that is how we treat it. If the close reduction fails, so the child presents to us even at a later date when he starts walking and has limp, and then parents sought the treatment. So after 18 months, close reduction might not also work, and the child actually requires open reduction. Open reduction, femoral osteotomy, and acetabular osteotomy. So all these things may be required in all the patients, or may not be required in all the patients. Open reduction, like in this case, open reduction and acetabuloplasty has suffice. So this was his her functional result when she presented 2 years down the line post surgery. Now, the next thing that I want to discuss is osteoarticular infections, which we commonly see in our OPD. The child presents to us with the swelling of the lower limb and fever, irritability, and inability to walk or inability to move the lower limb. So before thinking of any pyromyositis or a boil, we must think of osteomyelitis. One has to rule out osteomyelitis, then the things are quite easy. So osteomyelitis has to be ruled out. Osteomyelitis has to be treated properly with proper set of protocols. Why it is important to treat osteomyelitis? Because first, if it is not allowed to or not drained from the bone, it will damage the bone, make the bone weaker, and there are a lot of complication of infected bone. And once a bone is infected, it's very difficult to treat or eradicate the infection from the bone. So you can clearly see that I'm draining osteomyelitis, acute osteomyelitis. You can see how Olympus came out of a bone just by drilling a small 2 mm hole. So see the pus. You can clearly see that it is oozing out. The bone was quite under pressure, and as soon as we have drilled, the pus started oozing out. Similarly, septic arthritis. How do we diagnose septic arthritis? Look at this. The hip is flexed, abducted, and there is paucity of movement. The movement is also decreased. There is a paucity of movement on the affected side. So this is a suspension test. We must do it. So I have suspended the child. You can see that there is decreased movement on the right side as compared to the left side. On X-ray also, this can be diagnosed by increase in the joint space, especially the medial joint space. So on performing the orthotomy, you can see how clearly that this much amount of pus was there in a small capacity of joint. Treatment protocol for osteoarticular infection, there should be high degree of suspicion, raised WBC counts and CRP. We should get MRI whenever possible. Sometimes ultrasound may not diagnose a small amount of collection of fluid. Trial of broad spectrum antibiotic present within first 24 hours to 48 hours can be given, but usually we recommend decompressing the joint or bone. It will relieve the symptoms in a much better way and allows antibiotic to work properly by decreasing the infection load. In delayed presentation cases, surgery followed by IV antibiotic has to be recommended. So how long one should give the antibiotics and by which route one should give the antibiotics in osteoarticular infection? IV antibiotics till CRP comes negative along with clinical improvement should be the set protocol, and how long this antibiotic should be given. IV antibiotic till CRP comes negative and followed by a total of 6 weeks of oral antibiotics. So our total duration of antibiotic is 6 weeks. IV antibiotics followed by oral antibiotics. So what can happen after untreated or mismanaged bone and joint infection? This can happen even after our well-planned and well-executed management also, because infection damages the bone like anything. So just to show you the examples where the infection have not been treated on time, you can see that complete radius from both the bones of the forearm radius is completely missing, completely gone. Infection has eaten away the bone, and the child has developed gross deformity and limited movements. See, there is a fracture, pathological fracture after infection, and it has damaged the distal portion of the bone, and the damage is extending up to the growth plate, which may hamper the growth of the bone in future. See this, the complete head of the femur was damaged. Complete head of the femur was damaged. Capital physis has gone. So we have just stabilized the bone into the joint by doing an open reduction. This was the pre-op X-ray where the head was lying outside. We operated and put whatever the remnant into the socket so that the child walks with a stable gait. So my take-home message here is timely referral for any orthopedic condition to an expert colleague may alleviate a lifelong disability of the kid and the distress of their families. One timely surgery may prevent many future surgeries rather than sufferings. So I thank you all with this message. I appreciate your patient hearing. Thank you.